right, so this is our second podcast in the series for children with altered mental health, neurological, developmental, or learning disorders in the child with altered sensory status. You can see there as far as autism spectrum disorder is what we're talking about. I will tell you in 2018, the CDC reported that 1 in 59 children in the United States had autism. It is 3 to 5 times more prevalent in boys. The suggested causes are environmental chemicals, viral infections during pregnancy, chemicals in childhood immunizations, and familial patterns. We did already talk about the immunizations, but just so you know, we don't know the cause of autism, okay? This is not something that can be outgrown or cured, all right? The more quickly and the more interventions that we can put in place, the better the outcomes for the child. It is again on that DSM-5 manual. It is different than the 4th version. We're going to talk about the difference between what we used to be as an umbrella term to now what we consider as a spectrum disorder, okay? So here is what we used to do, all right? So we used to separate it, and you used to have to fit within one of these categories, all right? Autism, Asperger's, childhood disintegrative disorder, Rett's disorder. So we had to fit within those, and they were pretty strict parameters. But what we have done is we have created a spectrum, and we have defined it like this. So based on the development disorder of the brain, it depends on it's where they fall out on their spectrum, okay? Every single child is different, all right? The reason why there's so many more diagnoses is because, as you can see with this spectrum, a lot more disorders fit into this diagnosis, okay? Usually children, and what they refer to it on the spectrum, all right? When they say on the spectrum, means autism, show signs before 3 years old, all right? The more severe, the earlier they will show signs. So screening in Pennsylvania starts at 2 months. So they screen with the ability of the infant to gaze into the parent's eyes. Extreme cases of autism, and the babies cannot gaze into the parent's eyes, all right? Again, nobody knows the cause, but there are a lot of theories as to why. You can see here. So we used to separate it with social impairment, communication impairment, and behavioral patterns. But now we just talk about social communication impairment and behavioral patterns. There are criteria A, B, C, and D. You can see there. Persistent deficits in social communication and social interaction. Restricted, repetitive patterns of behaviors, interests, or activities. Symptoms must be present in early childhood, and symptoms limit and impair daily function. One thing from each of these categories must be present to be considered on the spectrum or autistic, all right? But this is how we are defining this now, okay? So I want to tell you that there are multiple, if you can see here, A1, A2, A3. So there's multiple different things within each category. They all have to do with social communication and interaction, all right? I do not need you to memorize each of these. What I need you to understand is all they need to do is fit one of these in each A, B, and C, and D to be considered autistic. So that can mean maybe they are poor social imitation, and maybe they have one thing from here, pronoun reversal, and maybe they have one thing from, they have a persistent focus of a sensory input, and maybe they have it impairs their daily life in some aspect. They only need one of each. All right, so you can see how autism might be extremely mild, and somebody could say to you, oh, your child is not autistic because they have mild symptoms. But that does not mean there aren't children whose symptoms are so severe that they are unable to function. There was a child in pediatric specialty care, which is one of our clinical sites. It's a long-term care facility for our pediatric patients, and there was a child there who had ADHD. He wore a helmet. He had multiple lumps on his head from repetitive banging. He had to be placed there because he was no longer safe at home. He was a danger at home to himself and his family. So it can be very, very mild where somebody will say, oh, you're not on the spectrum because you don't have, severe impairments, or it can be extremely severe. All right. So so you don't have to memorize each of these. I just need you to understand the concepts, okay, about how we are diagnosing people with autism. So children with social communication and interaction issues, generally, if you look here, they're not so good at interactive play, and they don't play well with others, okay? When we talk about the category for Bs, these are all symptoms of repetitive and restrictive behaviors with their interests and their activities. And you can see here the behaviors that accompany that. All right. As far as repetitive and restrictive behaviors, they don't necessarily always feel pain the way we do. They have a very high pain tolerance. This means that they can hurt themselves, unfortunately, and not feel it acutely, okay? And the symptoms need to be present in early childhood. You can see here. But I will tell you, this is very flexible now. So oftentimes, mild cases of autism are diagnosed while children are in middle school. The reason being is this is when they reach that level of a higher level of social interactive and communication, where children are being tasked to communicate and interact more socially, and this is where you're going to see problems start arising. So it is not that abnormal to see diagnosis of autism in middle school age children. And lastly, symptoms will limit and impair daily function, okay? So as we are defining the amount of impairment autism brings to each child's daily life, we are going to use those categories, but we're also going to use these levels. So level 3 is severe impairments, and you can see here they need significant support. And at level 2, they need support and their impairments are more obvious, but they're right in the middle there. As far as level 1, they do need support, but their symptoms and their impairments are mild. All right. Assessment, all children should be screened, and you can see there they should have referrals. They should have interdisciplinary teams, so multiple disciplines should be working with them. There are questionnaires, again, that accompany to help the diagnosis of this. There are no labs or x-rays, or again, it's based on behavior. All right, so they may need speech and language therapy. They may need occupational therapy, helps with social skills training and social situations. They might be on SSRIs, so Prozac, Zoloft, Paxil, Celexa. So you just discussed those. Those are going to help with those repetitive and obsessive compulsive behaviors. Stimulants will help with the hyperactivity and the impulsivity and inattention. And you may see some atypical antipsychotics and anticonvulsants used for mood stabilization, okay? Family support is very important in these situations. Nursing management is, so if a child with autism is hospitalized, we need to make sure we know what works and what doesn't work for managing the child and their behavior. We need to, as nurses, provide as structured as an environment as possible. Parents should stay with the child whenever possible. It helps the outcome and helps the child deal with the hospitalization better than they could on their own. If there are schedule changes, you need to let the child and the family know immediately. So if there's a delay with CT or ultrasound, you need to let them know immediately. But you also need to let radiology know, or the lab know, that the child is autistic, and the scheduling is what's going to help the child be successful during the hospitalization. These children will not be able to just go with the flow during a hospitalization, all right? All right, nursing care. So don't touch the child without warning. So don't just tell them, I'm going to take your blood pressure and put a blood pressure cuff on and expect them to accept that, all right? You're going to have to be very specific. I'm going to take your blood pressure. I'm going to put this cuff around your arm. It is going to squeeze, and then it's going to let go, all right? Be aware that textures and materials are something that is a factor with autism, so they may require things without tags. They might not be able to wear the hospital gowns because of the material. There are specific lines of clothing for children with sensory perception disorders. Limit environmental stimulus as much as possible. Speaking softly and gently. So this is what we talked about day 1 with treating children, right? Do not assume that the child cannot understand you, all right? Offer choices of menus. The parents might have to bring in specific foods because they might have some very different food ideas. I mean, we all have our own texture issues, most likely. Some people I've heard don't like potatoes, don't like eggs. I myself don't like the watermelon. It's a little, the texture for me is not great. My mom didn't like cornbread, that kind of thing. So they may have that to a whole nother level, okay? Make sure that you're getting all the input from the parents because they are the expert. Remember that they may have stimming behaviors, all right, to self-soothe. So as long as their stimming behaviors are not self-harming, you let them do it. You let them try to self-soothe. So finger sucking, rocking back and forth. We let them do those self-soothing activities and try not to give them any surprises in the hospital. All right. So moving on to cerebral palsy. Cerebral palsy starts with some sort of damage to the brain. Usually occurs at birth. It is not progressive. That means that the child comes out however the child is going to be. So if most of the brain is affected, they will have a lot of issues. If a very small part of the brain is affected, they could have very little impairment. I actually have a friend with cerebral palsy who is a disabilities lawyer in Philadelphia. She has very poor eyesight and she has a limp, and that's about it. So there's, again, a broad spectrum of what you will see with children with this disorder. Causes. Birth injuries, neonatal anoxia if the baby was deprived of oxygen prenatally, subdermal hemorrhage, infections, look at there, meningitis, encephalitis, so at or soon after birth. Lead poisoning, so lead is very important. It does cause cancer. It also causes it inhibits cognitive development, and it's permanent. It's not like you get the lead out of the system and the cognition comes back. That's not how that works. Head injuries, kernicterus, so that is severe jaundice. It's when that bilirubin gets so built up that it travels in the bloodstream to the brain tissue. All right. Low birth weight, infections during pregnancy. So cerebral palsy can be congenital or acquired. It used to happen a lot more often when forceps were being used, but now we use the vacuum extractors during birth, so it has gone down in prevalence. It is something that happens within the first year of life or before while the brain is still developing, okay? The pathophysiology. So again, every single case is different. No two cases are the same. It depends on how much and where the damage to the brain occurs. How we categorize it. So the two main categorizations are spastic or dyskinetic. Spastic is when the child is tensed, has jerky motions, and the legs tend to cross. Dyskinetic is purposefulness movements, significant emotional and behavioral problems associate with that. So these are your more floppy children. There is ataxic and mixed. I will tell you that you might see those two combined depending on where you are. In this purpose, we're using the 4 different categories, but those are not as common as the other two. As we categorize cerebral palsy even more, we need to understand that this is not the same type of categorization or reference that we would use for spinal cord, but it is similar, okay? So you can read there, quadriplegic, both arms, both legs are affected. The muscles of the trunk and face, mouth are also affected. Hemiplegic or hemiplegic, one side of the body is affected. Diplegic, so both legs may be affected. Arms may be affected to a lesser extent. Sometimes the lungs may be affected there. In cerebral palsy, there could be excessive muscle stiffness or complete muscle atrophy. Again, it all has to do with what part of the brain is damaged. As far as assessment, we're going to assess by what we see. Poor feeding during neonatal period. This is the first month of life when they're talking about that. Poor sleep pattern, poor motor signs. So this is dysfunction of the gross motor skills that we've already discussed. Persistent infant reflexes. So infants grow out of reflexes, right? But if they persist, that is abnormal and a sign of possible cerebral palsy. You can see here, the different reflexes. Increased or decreased tone. So here you have your floppy baby who is going to fit in the dyskinetic categorization. Here you have the hypertonia where there's crossing of the legs. This is what occurs, and when lifted from behind, their legs cross often in a scissor pattern, and that is signs of spastic. Early signs are inadequate reflexes. Again, the child may be stiff, may be floppy, so hyper or hypotonia, and the child will usually not meet early milestones. Okay. As far as diagnostic, you can see here are our options. The EEG is an electroencephalogram. This is showing how the brain is sending signals, or you might see a CT, but also diagnosis is from the symptoms and the signs and symptoms, okay? All right, so what can we do? Well, we're going to manage the symptoms, right? So, we're going to do pain management. We're going to manage the spasticity. The way we are going to do that is with padding, splinting, medications, surgical interventions like deep tendon releases, neurosurgical interventions, for example, inserting a backlift pump to continually deliver muscle relaxant. Okay, you see here the medications that we use to decrease the spasticity. Botox is used to relax the muscles. And you can see the other ones there. Okay. And here are a list of the medications and their uses and what they do, okay, that we would use for cerebral palsy. Here are the different things you might see for a child with cerebral palsy: mobilizing devices, surgery, technical aids, PT, OT, speech, nutritional therapy, education, vision therapy, hearing support, psychosocial support. This is a stand-aid. These are called MFOs. They're splints, walkers, all right? So all different types of equipment. You can imagine that can be very expensive, okay? Problems that occur associated with cerebral palsy: sensory deficits, feeding difficulties, dental issues, constipation, poor bladder control, chronic respiratory infection, and skin problems. Again, it's based on the area of the brain and the severity of the damage. I think we will stop there for our second video, We will start our third video with Down syndrome.